My pleasure this morning is to introduce our introducer. It'll be introducing Dr. Schmults, who is from Harvard, and we'll be talking about managing high-risk squamous cell carcinoma. But my introducer is one of our leaders, Dr. Jeff Callan. He is professor and chief of the Division of Dermatology. He actually is from Chicago, like me, and he's actually a Wisconsin Badger as well. But he's been on the faculty here at University of Louisville since 1977. He built a fantastic domain of dermatology here, and just always want to give thanks to our leaders, especially those who have stuck through all kinds of thick and thin at University of Louisville and made an enterprise that's really that we all can be proud of. So thank you, Dr. Callan. You're up.
Okay, thanks, Kim. Appreciate your kind words again. And I have the pleasure of introducing our visitor, who is Schmults. She is from Utah originally. She went to undergrad at Yale, eventually then went to medical school at Yale. She meandered across the country to Stanford for internship, and then came back east to train at NYU, which at the time was one of the premier training programs in the country for dermatology. Following that, she spent a little bit of time on faculty, and then she decided that she wanted to become a micrographic surgeon, and did her surgery fellowship with a gentleman in New Jersey, and then took a job and got a master's in clinical epidemiology at the University of Pennsylvania, before she then went back up further east up the coast, going away from her Yale roots to her competitor, Harvard, where she took a sort of a demotion. She was an assistant professor and went to an instructor at Harvard, but she has succeeded and relatively rapidly became a professor of dermatology at Harvard, which is quite an accomplishment because they're pretty tough on their appointments and promotions and tenure. I met, I knew of Chris for a long time because reading the literature, because she's been a regular contributor to the medical literature about skin cancer and about precursor lesions. And that's what she's going to talk to us about today. But I finally actually met her and broke bread with her at a meeting that we were both mutually at in Hawaii about a year and a half ago or so. And she's an excellent speaker and very interesting and highly competent researcher. So without further ado, let me bring up Chris, and she'll tell you about managing squamous cells.
Thank you so much, Jeff. That's probably the nicest introduction I've ever gotten, and especially, usually people are kind of reading stuff off. That's amazing that you just hold all that in your mind. I really appreciate that personal approach, and Jeff really takes the time to get to know people and mentor people, and he's been a phenomenal mentor to some very good friends of mine. So I'm glad for his personal hospitality. Welcoming me here, and I'm glad for the opportunity to talk with you all. Appreciate the invitation. Let's see. Let's maybe get rid of that. Okay. So I have a couple disclosures that are relevant. I was the NCCN non-melanoma panel chair. And we'll be talking about briefly about NCCN guidelines. We'll be talking about one of Regeneron's drugs, and I'm a consultant with them, and was formerly a researcher for them. And then I co-founded the Scout Consortium, which I'll tell you just very briefly about, and then we won't be talking about my main gig these days. So our main objectives here are that we want to understand our patients who have a risk of developing high-risk squamous cell cancer. We want to do what we can to prevent that with field cancerization management. We'll go into some details about that. We'll talk about NCCN and other definitions of high-risk squamous cell, and then related recommendations. And then we'll finish up by talking about what we can do beyond surgical management. We'll spend the bulk of our time on the surgical management, since that's our mainstay, but there are some exciting developments now beyond that. So I guess probably all of us, certainly all the dermatologists in the room, treat squamous cell cancer day in, day out. And so to what degree is high risk squamous cell even something that we need to worry about? The vast majority of these tumors are cured with our surgical excisions. Early in my career, when I was first on faculty at Penn, we started getting some of these big cases. The case mix there had a lot of these more advanced tumors. And that hadn't been the case really in suburban New York City where I'd trained. And so I went to the literature and I thought, do I need to do a CAT scan on somebody like this? Should I think about adjuvant radiation? And I figured that the answers would be there in the literature, but it turned out they really weren't. So it's taken us a while since then, over my 20-year career. I'll show you in this talk that we have made some progress. But we still face these clinical challenges of these more aggressive tumors. So trying to sort out, sometimes it's pretty obvious that you're dealing with something bad. But are there lesser cases where maybe you should be thinking up front about something more than just your surgery? And it was those kinds of cases that really got me into my whole line of research, which was around squamous cell cancer prognostics. So how many people do we think die from squamous cell cancer? There have been a lot of cohort studies now, and they all really have this very consistent 1 to 4% metastatic rate and about a 1% death from disease rate. It's actually higher in the UK, it's 4%. And I think it's because they don't use Mohs, but we'll get to that. And so then if you extrapolate that, we have 1.5 million squamous cell cancers every year in the US. And 1% of that is 15,000. And so that's quite a few deaths. With melanoma deaths, our melanoma deaths, they're dropping, fortunately, with anti-PD-1 therapy. So we're only losing about 8,000 patients a year in the US to melanoma. So it's possible that we're losing more people now from squamous cell cancer than we are from melanoma. Another problem with these prognostic estimates, though, is that unlike melanoma, which is recorded in SEER, the big national cancer registry, where there's really good mortality tracking, squamous cell is not part of SEER, neither is basal cell cancer, because there are just too many cases to record in SEER. It's just not practical for them to do that kind of tracking. And so we have to extrapolate this way. We don't have direct data about how many people die from squamous cell. So who's likely to get a bad one? Our work showed that people who get lots of squamous cell cancers eventually get a bad one. And this is some data here. The patients who got 10 or more, and this is dermally invasive squamous cell cancers, not in situ, that they have a 10-year risk of local recurrence of 37% or so, and over 25% risk of nodal metastasis, which is really, really high. So if you're one of these patients who just gets squame after squame after squame, sooner or later, you're set up to get a bad one. And maybe that's just statistics, or maybe there's something about you and why you're getting all these squames in the first place that's allowing them to be more aggressive. So who are these people who get them over and over again? It's really our people with field cancerization. A lot of these people are going to be immunosuppressed primarily from organ transplant or from CLL or other types of hematologic dyscrasias. And so they're pretty easy ways of knowing about these field cancerization patients. You really can eyeball it. And the non-dermatologists in the audience can also pick these patients out pretty well. You probably already do it every day. This is a very simple scale that you can use that I think can be helpful. Poikiloderma is just basic background sun damage, erythema, dyspigmentation, wrinkling. This is really a cosmetic concern. And so, we have all of our aesthetic treatments to address that. Then you have people with just little focal discrete actinic keratoses here and there. And those are just little areas of little bits of dysplasia, and you can just zap those with liquid nitrogen. Dermatologists do that day in, day out. Field cancerization, though, is when this dysplasia becomes confluent. And so you have people who they have a large area of their skin or a region of their skin, like their face, where you histologically, if you biopsied them, there would be lots of different areas where they would have some form of dysplasia. And these are the patients who really need our help. So here's a case in point. This person's in his early 40s, but he's a kidney transplant patient, transplanted in his 20s. And his whole skin here is just one big field of dysplasia. So we'll come back to exactly how to manage him here in a second. So I think of dysplasia. There's been a lot of debate in dermatology about actinic keratosis, where the dysplasia is only partway through the epidermis, and squamous cell in situ, where that dysplasia is the full thickness of the epidermis. And people have, in dermatology, have set this standard that we need to cut out all the squamous cell in situs because they're essentially just like squamous cell cancer. I don't think about it that way. I think that that's just all dysplasia. It's just all epidermal disease, just epidermal dysplasia. And there's a big difference between that and dermally invasive disease. So I have a dream that one day no in situ carcinoma will get surgery as a first-line treatment. Because we really don't need to do that in the majority of patients. And particularly for these field cancerized patients, they get so much surgical fatigue if we're constantly excising every single one of these. They leave care and then they come back with a really bad tumor. So we really don't want to demoralize people that way with excision after excision for epidermal in situ disease. Superficial basal cell is basal cell that's just in the epidermis. We can get an 80% beautiful randomized trial from the Netherlands for that. For in situ, the 2-year recurrence-free survival is 95% in this study of 137 in situs. If you combine topical 5-FU with calcipotriol. And so that's 95% of patients that you don't need to operate on. And that 5% where it does come back, just make sure that you're seeing these patients back. And anything that doesn't respond to that treatment, we usually go 2 rounds. If they don't respond to the second round of 5-FU calcipotriol, then we go ahead and remove it surgically. But you're going to end up doing far less surgery on these folks. And another really beautiful thing about the 5-FU calcipotriol combination is that only 7% of these patients that you treat will get squamous cell in that treated region over the next 3 years, which is as far out as they studied, versus 28% in the control group. And they found that the memory T cells were still present in the skin after treatment with 5-FU plus calcipotriol, but not 5-FU alone. You need that calcipotriol on board to recruit these T cells that stay in the skin and that keep doing this memory surveillance and presumably keep killing off the dysplastic cells as they form. Okay, so how exactly do I go about it when I have one of these field cancerized patients? I need to say that this is all off-label. These are not FDA-approved uses because there's no one who's actually making the 5-FU calcipotriol combo and taking it through FDA trials, sadly. That's a whole patent story that's maybe for a discussion. But this patient, he only ended up needing 1 surgery for all this disease. What I do is I take a look at this patient and I think to myself, what's dermal disease? And if it's clearly dermally invasive, and dermatologists can tell this well, then that's something that needs a biopsy and a surgery. What I do for a lot of small dermally invasive squames is rather than biopsy all of them and bring them back a second time, I just do a shave excision right there in the office for the small ones that don't need Mohs. And you can get those small dermally invasive squames under control very easily that way. Right in that same visit, all of these kinds of things that are hyperkeratotic AKs, that's all just epidermal disease. And you can tell just by looking at that there's no dermal component. So I numb up all of those, I shave them flat, or sometimes I just take a gloved fingernail and just scrape away these guys. And then I send that patient home with those little open abrasions, and right that day, or as soon as their cream shows up, they start the combo cream, the 5-FU calcipotriol. We do just 3 days on eyelids and lips, 5 days on the head and neck, and up to 10 days or until erosions appear on the trunk or extremities. Don't use combo cream on the genitalia. We've had a couple of cases, which I believe we published, of really terrible erosive scrotal dermatitis. And it seemed to be in effect. One patient was applying it suprapubically, but for some reason, even though it never got on the scrotum, he still got this terrible inflammatory reaction on the scrotum. We don't really know why that happens, but he needed oral steroids. It took weeks to clear, very painful. So for in situ lesions on the genitalia, we use 5% 5-FU, and you don't need it for too long, 5 to 7 days, maybe as much as 14 days for thicker in situ lesions in that area. Okay, so that's how I approach field cancerization. Maybe we can talk a little bit more about that at the end. And I just want to say a word about this entity of eruptive keratoacanthoma. This is an entity that we used to learn about, and then I think people stopped hearing about it for a little while. We renamed it as eruptive squamous atypia. Because when you biopsy these, they don't all meet criteria for keratoacanthoma. I've been referred patients with this condition where it was thought that they were getting in-transit metastases or just really rapid recurrences after surgery from squamous cell cancer. You have to recognize that this is a Kebnerizing phenomenon. And so that's one of your best clues to know, actually, that somebody has eruptive squamous atypia rather than true squamous cell cancer. Because when you cut them out, if you get new lesions within 3 months after clear margin surgery, that's very unlikely to be a recurrence, especially if they're studying right along, like this one here. You can see that Kebnerized line there. That's right along a surgical scar. That's a hallmark of eruptive keratoacanthoma. The other thing too is that nobody really just spontaneously gets, 20 or 30 squamous cell cancers on their extremities within a few months. It just doesn't happen. And so we need to remember that eruptive squamous atypia exists. I've had patients sent to me with requests for radiation or immunotherapy for this disease. And it's not really a cancer. This is an inflammatory eruptive reaction that we don't really understand. But we control this with intralesional 5-FU. And you can also give oral acitretin for refractory cases. And we usually, for the more aggressive ones, we also give them class 1 topical steroid to settle all that down. But we need to realize these are not true cancers. This is not out of control squamous cell cancer. This is eruptive keratoacanthoma. Okay, so then going back then to squamous cell cancer, true bona fide cancers here. How do we know which ones are risky? Again, we're taking the in situ ones off the table. None of them are risky. So for our dermally invasive tumors, the HACC 8th edition expanded T3 by quite a bit, which was helpful. But we took a look at it, and the problem is that T2 and T3 prognostically are very similar in AJCC staging. And these two groups comprise about 25% of our squamous cell cancers. And so we don't want to be upstaging 25% of all of our squames and getting CAT scans and thinking about adjuvant radiation and all that on 25% squames. So we need better prognostic stratification. And our Brigham staging that we developed still performs better than AJCC8. Our upper stages capture a similar number of metastases and deaths compared to the lower stages, but we do it in half the number of upstaged cases. So we're not inappropriately upstaging all those extra patients and exposing them to the potential for overtreatment. So what is Brigham staging? It's based on the 3Ds in PNI, the 3Ds meaning diameter 2 centimeters or larger, depth beyond fat, poor differentiation, and perineural invasion of large caliber nerves. If you have 2 to 3 of those risk factors, or 2 or more, then we consider you high stage. If you just have a single risk factor, we don't really consider you high stage, but I'll show you some caveats here to that. Well, in fact, here they are. So if you have just a single one of those risk factors, you do have an elevated risk of poor outcomes, but not terrible. You know, you can see here that when you get to 2 risk factors, that then especially your disease-specific depth starts to climb. Your nodal met risk, 11%. You know, that's high enough if it were melanoma that you'd be doing a sentinel node. So how do we manage these higher stage patients? I'm going to show you here how Mohs really does save lives, but first let's talk a little bit about what is Mohs, especially for the non-dermatologists here, and why is it different? So if you don't do Mohs and you do a standard excision that gets sent to pathology, they do vertical sections through that block. And they're not looking at the entire perimeter and underside of that marginal surface. In fact, they're only actually able to look at about 1% of the marginal surface. And so for our poorly differentiated squames, they're infiltrative, they're single cell spread, there's perineural invasion. You're very likely to miss tumor at the margin and not know it. Whereas with Mohs surgery or the Tübingen technique that's used in Germany and a lot of Europe, where they do the same margin, but the difference between Mohs and Tübingen is that Mohs surgeons, we read our own pathology under the microscope with rapid frozen sections. Elsewhere, in a lot of other countries, they do the same margin approach, but they do it with overnight paraffin sections and a pathologist reading it. Either way, they do the same precise mapping, and you're looking at the whole entire marginal surface here. All the way around and under. You're laying that all out on a block and you're orienting it. You can see here we have these different little colors here, so that if the margin's positive, you know exactly where that margin's positive and you can go back and re-resect exactly in that place. So why is that important? Because again, we have a lot of subclinical disease with these more aggressive squamous cell cancers. You couldn't have known when you started out over here on the left that the tumor was actually this large. Here's another one where we knew that this was a really unusual bad squame. She had some nerve symptoms, so we got an MRI and we knew that she had invasion all the way through her supraorbital nerve foramen. But what you couldn't see on the imaging was that she also had perineural spread going all the way up here to her hairline along a single nerve. You can only know that with Mohs or Tübingen, where you're really precisely tracing out where this tumor is going and resecting it. So I'm going to show you here that this level of precision in your margin resection makes a big difference for squamous cell cancer outcomes. So this is a large cohort, multi-center cohort of high stage patients. So these are all Brigham T2B squames, so 2 or more risk factors. About 50-50, this is a retrospective cohort, but about 50-50 got Mohs versus vertical sections. And you can see here that Mohs cut the risk in half of, let's see, which one is which here? Local recurrence and nodal metastasis. And then here's disease-specific death. Big difference. 17.5% chance of dying of your disease versus 7%. That's a big difference here. And so if you extrapolate that to all the 3 million cases of squamous cell that we think we have worldwide annually, you'd save about 30,000 lives every year, which is, again, about half of our melanoma deaths. Trying to put this in perspective here, if you use MOS for this high-risk disease. And even for the low-stage disease, this is just a single risk factor. You have a 3.5% risk of recurrence, metastasis, death with MOS, 10% with standard excision. So even for those single risk factor patients, you're going to be saving lives. And so the NCCN has taken all of this information together and stratified into low risk, high risk, and very high risk for squamous cell. This very high risk, they use different criteria a bit from what I've mentioned to you: 4 centimeter diameter, poor differentiation, any perineural involvement lying deeper than the dermis, and a lymphovascular invasion, which is one of the most important prognostic risk factors, but we were initially underpowered to prove that in our Brigham cohort study. So that's why it's not part of Brigham staging. The lymphovascular invasion is probably the worst of all. And so if you meet any one of those high risk criteria, you don't need 2 or more with NCCN staging, then MOS or tubingen, that total margin control, is the NCCN preferred treatment for those tumors. So I'm not just saying this, NCCN is saying this. This is an NCCN cancer guideline. So we need to make sure that these patients who meet NCCN criteria are getting MOS or an equivalent margin with rapid paraffin sections. We put out a paper, some folks from the NCCN panel, about how to do this if you don't have MOS, or if the MOS surgeons just don't feel equipped to be able to deal with some of these very extensive resections, and if they don't have access to general anesthesia. Some of these deeper muscle resections can get pretty tough to achieve under just straight local, which is what most of us operate under. You really can coordinate and do these cases in the OR, either with a MOS surgeon or with surg-onc. But there needs to be coordination. There needs to be this kind of orientation where you're mapping out your margin, you're inking the marginal surface so that when it gets grossed by the pathologist, they know where to cut, making sure that the surgeon knows which piece is which. And then you can really go back and again re-resect right where there's tumor that's positive. And as far as we know, whether you do it in the OR that way with a pathologist involved or whether you do it with a MOS surgeon, probably the outcomes are the same either way, so long as you're doing that, that close communication and that proper orientation and mapping relative to the wound bed. Okay, so that's it for surgery. So now let's move on and think a little bit about when surgery might not be enough, even with our best MOS resection. So even with MOS, we have this 10 to 15% nodal met risk for our Brigham T2B people with 2 or more risk factors. So what do we do about those folks? We get imaging, baseline imaging with a CAT scan of the draining nodal basin for all of our Brigham T2B people. And we keep doing 6-month CAT scans until they're 2 years out. The majority of people, if you're going to get a lymph node met, it happens within 2 years. So all of our T2B folks and higher, again, 2 or more risk factors, they get radiologic staging and surveillance. in terms of adjuvant radiation, we know from a few different studies that the recurrence risk is cut in half when you do adjuvant radiation. So then it all becomes about knowing your baseline risk, because a lot of our high-risk squamous cell cancer patients are elderly and frail, and it's actually pretty tough for them to show up, 5 days a week for 6 weeks for radiation, and they are worn out by the end of it. I don't know if we have any radoncs with us here, but it's hard on older folks for sure. And so if your baseline risk of recurrence is 10%, which is true for a lot of these folks, then going from 10% to 5%, most of my patients don't want that deal. They're very happy with their 90% cure rate, and they'll take that. It's just not worth it for a 5% gain. If your baseline risk of your tumor coming back is 20%, and you can take it to 10%, then that starts to be a little more meaningful for people, and you'll have a lot more patients who want to take that deal. So how do we know exactly what that baseline risk is? Well, let's see, I'm a little out of order here. So first, let me tell you about adjuvant cemiplimab here. So there are things that we can do in addition to radiation. So as I just told you, that radiation cuts that risk in half. If you add cemiplimab on top of radiation, so in this study, 415 patients were randomly assigned after getting their tumors fully surgically resected. They all got radiation, and then half of them got half got placebo and half got cemiplimab. The 2-year disease-free survival definitely dropped with the people who got cemiplimab on top of the radiation. So cemiplimab is advantageous on top of radiation, but again, this is a lot of treatment. And if you already had to talk your patient into radiation, and then you're going to do a year of cemiplimab on top of that, it's a lot of treatment. So again, it's all about your baseline risk. And if your baseline risk after radiation was 36% and you take it down to 13%, then that's important. That's worth doing for most patients. But it's going to be a rare patient who still has a 36% risk of recurrence after radiation. So who are we doing adjuvant cemiplimab on? We put together this list, which is essentially the inclusion criteria for the trial, or we also consider it in patients who have this 20% or greater risk of recurrence based on the RISC app, which I'm going to show you in just a second. So people with in-transit metastases, bone invasion, nodal metastasis, except for small nodes, N1 nodes, ipsilateral, small, less than 2 centimeters, no extracapsular spread, perineural invasion, except for a single nerve that's small caliber. These are the patients who we're considering for that adjuvant therapy, because they all have about this risk of 20%, and they're the people who were included in the trial that I just showed you. Okay, so this RISC app, this is worth taking a picture of. I don't know if you guys are allowed to do that, but one way or another, make sure that you know this website. This is a really beautiful app here. What you do is you just set up your account, which takes 2 seconds. It asks for, I think, your medical license number, but if you don't know that off the top of your head, you can actually just put in any number. They're just trying to keep people out, like that, the whole wide world. So once you have your little app set up, then you just put in, for any given patient, you just type in these couple factors here, which is super quick. And then it gives you these beautiful risks. You'll notice that they're stratified by Mohs versus excision. And for this particular patient, we are cutting that risk in half if we've done Mohs. And we have these lovely 95% confidence intervals here, which are really quite narrow. This prognostic app was developed by my partner at Brigham, Emily Ruiz. And it's based on that big 12 center mega cohort. So based on all that data, every time you put this in, it runs the algorithms from that database to give you these prognostic estimates in the 95% confidence intervals. Okay, so we'll just close up here then with neoadjuvant. So, we know then that doing something after surgery can really help to improve the outcomes for these high-risk patients. And we now know how we can counsel patients based on their own individual risk using that Risk-C app. But could we do even better if we were treating people with just a short course of cemiplimab before surgery, rather than waiting till after the surgery and doing a year's worth of therapy? So this study showed this great 51% complete histologic response. And these were advanced cases. 60% of these folks had nodal mets. Most of them were stage 3-4 tumors. And just 4 doses of cemiplimab every 3 weeks, and then surgery. We're currently using, I think, just 3 doses. There were several dermatologist authors, including Emily Ruiz, who I just mentioned, Vishal Patel, who's in DC, and 2 of our German colleagues. And so, this is an area where dermatologists are really contributing to this data on the management of these advanced cases, which is very exciting. And so who are we actually giving this to? Definitely folks like this. And we're starting to expand our criteria a bit, but we think about neoadjuvant for people who are borderline resectable to start with, where you're not really all that confident that you're going to get a clear surgical margin or be able to get this tumor under control with surgery alone. If the patient's facing a highly morbid surgery, like this lady here, she was going to actually need an amputation because this was in the joint space. And she's 93 years old and is not going to do very well with an above the knee amputation. So that's someone where neoadjuvant is a perfect option. And if you can get them into a resectable zone, then you can spare somebody that really highly morbid surgery. And then we're thinking about it for some other subsets of patients. So I mentioned lymphovascular invasion. If you have one other risk factor, your death from disease risk is about 25% with lymphovascular invasion. So that's high enough that this is the kind of patient where maybe you want to really jump on this tumor up front. In-transit metastasis, this is someone with in-transit mets. He started out with just this little tumor, and then by the time I saw him a few weeks later in clinic, he has that. And that, when you have that kind of really rapid spread, and this is a young, healthy patient, this patient just had bad luck. He had nothing else wrong with him. This is the kind of patient who is a perfect candidate for throwing the book at it. 59% or almost 60% risk of being dead from disease 5 years out if you have in-transit metastases. So these are the kind of folks where we really want to jump on it and think about a systemic approach. Because the other thing, when you have disease like this that's on the move, or this poor patient who had ataxia telangiectasia and a chronic ulcer since he was 4 years old on his arm, that finally degenerated into this really terrible squamous cell cancer. These are people who almost certainly have nodal metastases, even distant metastases, potentially seeding. And so getting a systemic therapy on board sooner rather than later is really the way to go. All right, I think that's about it. So just to wrap up here, our cutaneous squamous cell tumors likely kill about as many people as melanoma. We have somewhere between 7,000 to 10,000 US deaths annually, most likely. Mohs or the equivalent margin, working with a pathologist is the preferred treatment. NCCN preferred treatment for very high-risk squamous cell cancer, meaning tumors with any one of these risk factors listed here. And we could save about 30,000 lives worldwide every year if we follow the NCCN guideline to do Mohs or a Mohs margin. Local recurrence and death risks are low when you do use total margin controlled surgery, but even with Mohs, for these high stage patients, you still have about this 10 to 15% risk of nodal mets. And so do your radiologic staging and surveillance. Use the Risk-C app to really know where somebody stands prognostically, ideally before surgery, so that you can show them how much their risk would drop if they get Mohs. But sometimes they're not fully staged until after their surgery. And then again, consider neoadjuvant therapy for people with all 4 risk factors: lymphovascular invasion, in-transit mets, borderline resectable, and adjuvant therapy. We're usually doing that. We're thinking about that after surgery and after they're fully staged. All right, couple thank yous. Anoki Jambusaria did some of the data that I was showing you about field cancerization, and she put together that nice 3-point grading system to know when you have field cancerization, defining that definition. And then Emily Ruiz did a lot of the work on radiologic surveillance that I showed you, and the risk app. Thank you.
Thank you so much, Dr. Schmults. I think most of us were kind of in stunned mode looking at the lesions and
Yeah, shouldn't have mentioned that. I forgot to give a little warning.
Actually, Jason did. He sent out a warning yesterday.
Oh, really?
Jason. My question is, how can we stop any of this from happening? And so, you know, I know at the AMA, we actually had the American Academy of Dermatology offer, it was fluorescent light screening, I believe, or, you know, had everyone who wanted to come in and have, but there's got to be tools that we could use that are inexpensive, quick. Maybe it's take a picture of everything and submit it to an AI app. I mean, there's got to be something that we could do to get these lesions early.
Thank you for asking that. So a couple slides that I really should have put in this talk. First, daily sunscreen, even just SPF 15, daily sunscreen in old Australian studies cuts your risk of getting a squamous cell cancer by 40%, I think it is. So all of our patients who have any dysplasia at all should be on daily sunscreen. Nicotinamide. Nicotinamide 500 milligrams twice a day, also from Australia, cuts squamous cell cancer by 30%. There was an underpowered study saying that it didn't work in transplant patients, but it was it actually was working in transplant patients. They just ended the study before they were powered to show the difference. And so we have all of our, anyone who's had just a single squamous cell cancer, we put them all on nicotinamide, 500 milligrams twice a day. That plus the combo cream, the 5-FU calcipotriol, our patients with really bad field cancerization, they do it on their affected areas about twice a year. Our less affected patients do it about once a year. And with those 3 things, daily sunscreen, oral nicotinamide, lifelong, and the combo cream once or twice a year, we really drop their squamous cell cancer formation rate. And we take people from, you know, having like 10 tumors a year removed down to 1, you know, every year to every other year.
So that was actually way more important than what I was asking. I was asking about screening, and you gave us prophylaxis, which is probably brilliant. But is there something we should be doing for screening in terms of?
I think you can just kind of look at people. You know, that's one of the great things with dermatology, and skin cancer in general, where it's, I guess one other caveat to that is for organ transplant patients, there's something called the sun track. That's another thing that I should put in this talk. It's 3 or 4 different factors, and I could send this around afterwards. But that's a way that you can risk stratify people without even seeing them, and doing an exam to know if they're likely to ever get a squamous cell cancer. For the non-transplant folks, well, I think everyone with CLL should be screened. You know, anyone with CLL or any other kind of hematologic dyscrasia, all those patients should see derm at least once a year. And then if you apply the SunTrack criteria, the people who meet the SunTrack criteria, they should see derm, and that's all spelled out in that paper. And then I think just, you know, white people over 50 should get probably a baseline check just to see how much sun damage there is. Do they have field cancerization? And then they get on our prevention strategies.
So a couple of questions so that you raised. You said that you give almost everybody you're giving niacinamide to.
Yeah.
Many of these patients are older and they have hyperlipidemia and they're on a statin. And as soon as you, in the electronic record, prescribe niacinamide with a statin, you get a warning that the risk of myopathy from the statin is going to be increased. How do you handle that? Do you worry about it at all? Is it a real risk? I think one time when I was talking about that, long time ago, when the Australian study, the New Zealand study first came out about using niacinamide, and I talked about it at Grand Rounds that reviewed that paper. Here at Medical Grand Rounds, one of the cardiologists said, "Oh, we often use niacinamide to enhance the effect of the statin, and don't worry about it so much in the doses that we're using." How do you handle that? And Kim, maybe you want to weigh in on that since you're a cardiologist.
HBS2 Thrive and AIM High both showed an increase in mortality trying to raise HDL with niacin and its derivatives. So we kind of like opted about, oh gosh, 10 years ago. Yeah. So if it has other usefulness, great.
Do
Okay.
you worry about the toxicity?
So well, we don't use it anymore. So no, I mean, it was, you know, I love that so many people hated the flushing and the skin phenomenon that people had it.
Well, that's why we use, so we don't use niacin.
Right.
Because we use niacinamide because there's flushing is a lot less of a problem.
Exactly. And then the worry is that they're so similar in terms of their effect on HDL, which was good, we thought, but now we know that raising HDL actually increases mortality, so we don't do that anymore.
So yeah, so okay, so now we have another thing to worry about.
Actually increasing mortality. There was a recent paper about cardiac effects, but when we reviewed that at Journal Club, we felt for various reasons, including some things about the study design, that it hadn't really shown a problem with oral niacinamide.
Yeah, another thing is, so you mentioned CLL. So there are a lot of people who have CLL, but they're not being treated, they're just being actively surveilled. They have active disease. There are other patients who've had B-cell lymphoma, whether it's CLL or B-cell lymphoma, they get treated and seemingly they're cured. And my observation, I think, and I want your opinion about it, is that those patients still are at high risk. That even though you are rid of your B-cell lymphoma or your CLL, that you're still seem to be at high risk for developing aggressive non-melanoma skin cancer.
Yeah, we did a study years ago of CLL patients, and we broke them into high stage squames, low stage squames, and high rise CLL and low rise CLL. And rather predictably, the people who had both bad CLL and bad squames did the worst. But what was interesting was that a lot of those people, they'd had historically high rise CLL, but then it had gone away. You know, they'd been in remission for several years, and they got their high risk squame after that. And so it goes to your point that I think there is some kind of permanent immunologic alteration that we probably don't really understand. And maybe it has to do with these T cells, that sit and do surveillance in the skin. Maybe that changes with CLL and you don't go back to normal.
So I see online, we have with us Robert Ammons, who's one of our hematologists. I wonder if he has any comments about that. And I also see that Rosemary Usef's online, who's a chief of nephrology, and I wonder if she has any comments about the transplant patient population. And then I'll ask you, Chris, about whether or not switching from tacrolimus or cyclosporin to sirolimus makes a difference in the outcome of squamous cells. And then we can ask our nephrologist if that makes any difference to their control and prevention of rejection.
Okay.
Yeah, Dr. Emmons actually posted a question in the chat. He says, what understanding do we have about the cutaneous and systemic immune issues that permit the field effect for SCCA? Are there any known defects that can be screened for, so T, NK, APC?
Yeah, so they've done GWAS studies, and we do know that that the sun causes P53 mutations and then a whole cascade of other mutations. Basal cell and squamous cell are the most heavily mutated of all cancers, and so you get this UV signature from light. And people with more pigment in their skin have melanin caps that actually protect their keratinocytes from that ultraviolet radiation. And so that's why this impacts people more and more the less pigment they have in their skin. And so, those really are the precursors. It's just not having enough pigment in your skin to prevent UV damage. And I don't feel like we have to look a whole lot further for UV induced cancers. I think though there's a whole other thing that we don't know much about. I showed you the patient with the chronic ulcer since childhood. When people get squamous cell cancer and chronic wounds like that, and it's more of because of the chronic inflammatory setup. And then of course we have our anogenital, sometimes HPV based, sometimes not, those kinds of squames. Those are different kettles of fish. But yeah, I think in terms of just your run of the mill UV induced squamous cell cancer, it's just lack of pigment that that caused the trouble.
And then my last sort of comment is, you talked about sunscreens, but sun protective clothing to me is even more important. So hats that have a brim, not just a brim that goes out on front, but one that goes all the way around, like Tilly hats.
Yeah.
Are really useful for people. And I praise my patients, some of the residents that have been with me, and I praise my patients when they come in wearing their hats. And then I chastise them when they're not wearing their hat. And they're going out, and I see them going outside of their car, and I know that they're not ever wearing their hat. Or the hat that comes in and it's a straw hat, and the hat has a big brim, but if you hold it up to the light, you can see all sorts of light coming through. I don't like those hats either.
Or visors.
No.
Yeah.
Actually, we have a question.
Hey, Jason, can we get a response from Dr. Emmons that Dr. Callan asked, or Dr. Usef?
About the
So if anybody can hear me from where I am here, the previous theories of carcinogenesis in general have relied on mutation rates exclusively as the genesis of cancer. But the more we study this, we know humans contain vastly more mutations than they develop cancers. And as of the advent of checkpoint inhibitors, successfully first shown in the New England Journal in 2015 for melanoma, we now know that the immune system is at least as responsible for the full development of cancer as our mutation rates themselves. So the future of cancer screening will involve not only methods to decrease mutation rates, but improved understanding of the immune senescence that accompanies sun damage, aging, and other things that contributes to the ability of cancers to fully express, especially the field cancers that you showed. Those are probably not just mutations, but rather permissive aspects of the immune system that allow this wholesale, essentially growth and takeover of the skin. Currently, we don't have the ability to screen for those defects, but the modern ability of cancer screening will not simply be to find lesions or to find mutations, but to find the immune defects that predispose patients to these very difficult cancers that escape treatment and detection because really of the immune system, not intrinsically the biology of the cancer itself.
Yeah, and I think in cutaneous squamous cell, it's such a great illustration of that because of the problems that we see with CLL patients who have a whole host of immune dysfunctions, and our transplant patients. To go a little bit more to the question about transplant patients, so azathioprine is, there's some data to actually support this. Azathioprine is the worst drug in terms of skin cancer production, and the mechanism is actually known. It does something, I can't quite remember what it is, but it actually potentiates UV damage. And impairs our ability to fix it because, you know, we have DNA repair enzymes, and it's thought that nicotinamide works because it boosts our DNA repair enzymes. Maybe it has an immunologic effect too, I don't know. So getting people off of azathioprine, if they're on it, that's the first thing that we really encourage in dermatology. And then conversion to an mTOR inhibitor. You know, that's always a little bit of a balance. And I know, you know, different transplant centers and different transplant docs have different views of the side effect profiles and the problems with mTOR inhibitors. But there's pretty clear data that if you can be switched over to an mTOR inhibitor, especially after your first squamous cell cancer, that it does preclude you from going down this road where you're one of these multiple squamous cell formers.
One quick question we have from Dr. Satya Krishnasamy. She's our fellowship director in endocrinology. I want to know how has AI impacted the pathological and prognostic assessment in this cancer?
Wow. Not yet, but actually, Emily Ruiz, my lovely colleague, she's doing a whole line of work with that. You know, scanning a whole bunch of images. So is John Carucci at NYU. So there are definitely people who are on this, trying to train on AI to pick up things histologically that we're not. I think though you know, it's a little too early to tell where that work's going to go.